Well, we are at the top of the hour, so I'm going to go ahead and start. Hello, everyone, and welcome. Thank you for joining us for today's Let's Talk Compliance Roundtable event, the Telemedicine Cliff. Before we get started on today's presentation, we'd like to cover a few housekeeping items. Today's presentation is being recorded for post-event viewing. It should be live early next week. If you have a question for our presenters, please type your question into the meeting chat feature. We will do our best to cover all of your questions throughout the presentation. If you experience any technical issues, please refresh your browser or leave the meeting and join back in. If you continue to have issues, please contact Foley's tech team at videoconferencing@foley.com or dial 1-866-319-5800 extension 2, and we are going to put this all in the meeting chat so you have access to that. As a final note, a short survey will appear in your meeting chat at the conclusion of the program, and we would appreciate it if you would provide us with feedback on today's webinar to help us improve our future programming. And now I'll turn it over to Jana Kolarek and Angie Caldwell to introduce our presenters and begin the presentation. Jana?
Wonderful. Thanks, Maggie, so much. So welcome, everybody. As Maggie said, we're super happy, Foley is, to join with PIA in the next, or the latest, I should say, of our Let's Talk compliance events. So we've tried to make this a quarterly thing with you guys. So this is the latest. It is more of a Q&A format, so we welcome your questions. We've asked for them in advance, and you guys have quite a few of you have readily supplied them, so thanks for that. I'll be introducing TJ, my colleague in Tampa. He is a partner and board-certified healthcare lawyer with Foley, where he focuses his practice on telemedicine, digital health, and virtual care, as well as a wide range of transactional and related regulatory issues for health industry clients. He works with physician groups, hospitals, entrepreneurial startups to build telemedicine arrangements across the United States as well as internationally. And he has considerable experience in structuring and negotiating healthcare transactions, including M&A, joint ventures, strategic affiliations, and financing. TJ speaks frequently at conferences like this one across the country on telehealth, virtual care, and healthcare innovation legal issues. So we're very happy that TJ's here. And Angie, you want to introduce us to Valerie?
Absolutely. Thank you, Jana, and thank you, Foley and Lardner, once again. We truly love these sessions and Let's Talk Compliance. It's such a unique format, and we are happy to partner with you and bring this to the audience that's with us today. I am Angie Caldwell. I'm principal with PYA in the Tampa office, and it's my pleasure to introduce to you my colleague, Valerie Rock. Valerie is a principal with PYA in our Atlanta office with 18 years of experience. She serves in our compliance advisory service line. She specializes in physician coding, reimbursement, and regulatory compliance. And if you haven't spoken with Valerie, she absolutely loves this stuff. And I learn something from her every single time I speak with her. So I hope that the same happens for you today as part of this session. Valerie is also a key leader for our PYA's internal mentoring and leadership programs, something that you might not know about Valerie and her background. So with that, I'm turning things over to Valerie and TJ. Take us away.
Great. Thank you both, Jana and Angie, for the introduction. We're happy to be here. TJ and I spend a good amount of time in this area and are glad to share our thoughts about where we're going with telehealth. But want to kind of frame out what we'll be talking about today, but also want to make sure that you know what we're not going to be talking about. We tried to buy a crystal ball on Amazon, but it was back ordered, so we're going to be able to provide you the information explicitly about how things are going to happen with telehealth going forward. We apologize for that, but supply chain is an issue. So we will give you our best guesses and help you make educated guesses going forward, because there are a lot of levers that are impacting how you will be looking at telehealth going forward, how you'll be implementing it going forward, how you'll transition through the PHE. So that's really what we'll be talking about today. So we're going to start with where we were prior to the PHE, then talk about where we are, and then start looking at the laws and the levers that are impacting, again, what you'll need to determine going forward to make decisions. And then how do you prepare your teams, your entity for the transition after the PHE? So we'll start at the top. So where were we pre-COVID? We have a Social Security Act law in section 1834M. It has 5 requirements. These are the things that have been, hit over and over and over again, probably in everything you've heard, but we don't want to not cover this, because this is one of the most critical aspects of what is going to happen going forward, especially as it relates to Medicare. So the 5 requirements are the geographic requirement, where the beneficiary has to reside in a rural area. The location requirement, where the beneficiary has to be physically present in a healthcare facility when the service is provided. The service requirement, that the telehealth list of services that are approved by CMS are the only services that will be covered under a telehealth provision. The technology requirement, that you have to have audio and visual capabilities within the system and have interactive communication with that patient and provider. And then the provider requirement, where the provider has to be an approved provider under the section as well. So TJ, you want to talk about any more about that federal piece in addition to the state and licensure piece as it relates to historic?
Yeah, I'll just emphasize that the criteria Valerie just enumerated is specific to Medicare fee-for-service, which when we talk about Medicare, that's the big elephant. That's the largest payer in our country. It's the largest beneficiary pool. So typically and historically, where Medicare goes, and sometimes slower than in some cases than in others, goes the rest of the healthcare industry in a lot of ways. And so that's why it's so important, is that before COVID, we did have some momentum here in the telehealth industry. We were making progress, but it was slow, and we sort of got this big, boost, explosion because of the pandemic, and we moved into it much more quickly than otherwise. So when we talk about, our title is the telehealth cliff. Well, what's the falling off point, or what are we falling into? And I think we'd fall back in time into what a lot of those pre-COVID-19 rules were, which were very draconian, the ones that Valerie mentioned. And as a result, the data even back then was the utilization rates were, for Medicare fee-for-service at least, significantly low. They were insignificant. They were a drop in the bucket for the $600-700 billion spend. It was less than 100 million going to these services, which I think was driven primarily because of the very strict requirements that she just mentioned. So when we say, we wanted to talk about what it was before, it's so that we can all remember that if certain things end from the public health emergency, this is the world that we would go back into.
Right. So let's move into some industry trends and talk through that. So one thing that I kind of hearken back to when I think of the telemedicine movement forward is when the EHRs came about. And when we were trying to move forward with EHRs, we had a lot of EHRs coming out. There were a lot of little EHRs that were trying to become big EHRs, and they started, kind of molding together and merging together to become bigger entities, and some of them survived, right? And some of the tracking and trending and everything survived, and they made mistakes and they did things that didn't make sense, and we gave them feedback, and they started becoming better and better and better. I see that same type of trending with telehealth, where everybody's trying to do everything, every type of vendor, every device, and staffing models and hospitals and physician practices are trying to get their hands on this, and what are they going to do? And everybody's trying to make a decision, and Medicare is trying to come out with rules because of the pandemic to capture all of this. So as this continues to trend, we'll start seeing it kind of calm down and become what our norm would be. The challenge, of course, is that we're still in the middle of a pandemic. We're still in the middle of something that is not normal. So the hard part is figuring out how to get to a normal within that. So TJ, any additional thoughts on what you've seen with the industry, with your clients and other conferences that you've been in, and how the industry is talking about this?
Yeah, so the question I'm getting the most of, and at Foley, I think we probably do more telehealth work than any other law firm around. So moving around the clients, the conferences, where I'm seeing the most consternation, or where a lot of energy focused, is the exact topic of our presentation today, which is what's next, and both in the near term and in long term. And I think to understand or answer that question, we want to think about, well, how does this work, this waiver flexibility period we're in? And so understanding what does this mean by the public health emergency? What is that, or how does it end, and how would that work? And this was something that was put in place and announced by the HHS secretary last year, right back, I believe it was in February, can't remember the exact date. And the way public health emergencies work from a legal perspective is they work in 90-day increments. So it's not like last year we were like, hey, we're going to be here where we are today. It's every 90 days. And at the end of the 90 days, it can just end. There's no legal requirement that anybody give notice to the public or to the industry. There's no requirement that the administration extend it. And last year, the prior administration, it was a source of a lot of consternation, because we got down to the wire quite a few times. And a lot of this was new, so no one knew how long and to how much it would be extended. So earlier this year, the Biden administration did send a letter to governors saying, hey, look, we expect to continue to extend this through 2021. I remind all my clients that this is the lawyer caveat, that they're not obligated to they could have lied, right? They're not obligated or bound by any way to do that. I think it would be political suicide for them to have sent that and not do it. But crazier things have happened by various administrations in Congress, right? So not to say we don't trust them, but we should be wary. For example, the last public health emergency extension was July, I think 19th or 20th. So October 18th. So here's an example, right? We're 10 days out. We haven't heard anything, crickets. Why haven't they told us they're going to extend it? Why haven't they just gone to extend it? But they haven't. So what I hear a lot, or to go to your question, Valerie, is, well, what's the trend? The trend is everyone's watching, waiting, and pushing to try to extend these further, to kind of at least get some certainty and confidence, because we are in a world of uncertainty right now. So even with the statement of the end of 2021, well, we're getting towards the end of the year, we haven't had any guidance from the administration, explicitly or implicitly even, on what they plan on doing next year with the public health emergency. So that's the biggest one. This is it's really important for the industry. Earlier, and I think it was July, there was 430 organizations that sent a letter to Congress together. A lot of them were large organizations, key stakeholders in healthcare and virtual care, to Congress, basically saying, hey, in case you weren't aware, which you should be, there's this thing called a telehealth cliff that's coming up. And Valerie and I could talk about more about how that would work or what it means, but they sent it to Congress. This is very much on the minds of, I think, some decision makers. It's highlighted in CMS's recently released physician fee schedule, the proposed rule. So it's out there. The question is going to be, well, how is Congress and how are our agencies, federal and state, going to deal with that?
So let's also talk about the data itself. When we saw an uptick of the data for telehealth in April, March, April, May, and then kind of a downward trend, coming to current, and it's kind of gone up and down a little bit. All of that is based on us being in the midst of COVID and being responsive to that, doing service when a physician may not normally be okay with doing a service telehealth, in a telehealth environment, but because of telehealth, or because of COVID, they decide to do a telehealth visit. It's not really the best situation, but it's better than nothing. So we wouldn't expect that to be something that would happen in a normal environment where, once everything, knock on wood, calms down, that we would get to a place where the physicians are like, I'm not going to do something where I can't do a full visit and make sure I'm fully examining the patient and things like that. So what are the expectations for, kind of a go forward basis? Where can we maybe expect to land, do you think?
Yeah, so to kind of break up that question, I would say is one way to kind of address some of these, the ending of some of the flexibilities is to think about them in an order of importance, or at least this is how the legal analysis would go, is there's you have overarching rules from a state level, you have rules from a federal level, and then you have all your payer and reimbursement rules. And you really have to look at each of those separately. And I always start with the state law, because if you're in a state, your license is at issue, whether it's your hospital license or your professional license. And it doesn't matter how you get paid, it doesn't matter what you're doing, that comes first, because they can take away your license and then you can't be practicing in the first place. And so you had pre-COVID, there was actually a fairly good trend of industry statewide uniformity and flexibility. It was moving that way. And I appreciate it, because back in like 2015 or before, it was very much haphazard, and it was really poorly drafted. A lot of these legislative statutes, they were very prescriptive. They were very not based on clinical reasoning. It was just arbitrary. Over time, they had started to uniform their state legislature rules on telehealth practice standards, licensing, et cetera. And so it was nice, because we do at Foley, we do a lot of 50-state surveys, we do a lot of updates. And so a lot of our team of folks that update those, it was getting easier because there was less changes, or they were more uniform to the model acts. Well, COVID happened, and now everyone's looking at their own statutes again, and they're kind of making their own independent changes, which were kind of way back to how we started. Now, some of these are helpful, some of them have unintended consequences and all of that. So the waivers came in, and then some are going to be extended, some are going to be made permanent. Like an example was, Florida was great, super broad. They said basically, if you're licensed anywhere, come provide services in Florida. You don't need a Florida license. But then on June, whatever, something, it just ended. Very little glide path, no warning, it was just over. So it's an example of abrupt change there. Then you have issues like Ohio, which said, hey, historically, Ohio folks could not conduct controlled substance prescribing via telehealth. And they said during COVID, you can do that. We need to get this type of treatment to patients. And then in June, the Ohio board says we're going to end this in 30 days. So September 17th, it's over, party ends. And then in August, they're like, never mind, well, let's wait until December. And so folks operationally are pulling their hair out, because they're trying to thread the needle. They're trying to utilize these waivers, because that's the whole point. But these things are ending haphazardly. New York was another one. They ended in July, but then now with the healthcare shortage, the healthcare worker shortage, they said, you know what, we need to go ahead and pass more waivers. So those are operationally the boots on the ground folks are trying to deal with from the state perspective. And that is regardless of how you get paid. So that's the first level I look at. And then on the federal level, it's a similar analysis, because there's really important waivers there. So you had the OIG come out and say, during the public health emergency, we are going to use our enforcement discretion. And so we're not going to come after folks or healthcare providers if they waive copays, if they waive cost share obligations, particularly in the telehealth context or RPM context. And that was great, because a lot of these hospitals, doctors, telehealth companies, that's a real point of friction. Or if you're a new doctor, you don't have a real easy medium perhaps to collect that copay. And so would you just not do it because you were worried about getting an OIG, enforcement action? So they waived that. They waived at the OCR. They were much more lenient from a HIPAA perspective, where Zoom just came into play. Zoom traditionally was not maybe considered a healthcare compliant or HIPAA compliant type of tool. Now they have products. They were using all kinds of stuff. Didn't have to sign a BAA. They were saying you should, but we're not going to ding you for it. And then the third big one from a federal agency perspective was the DEA said, hey, there's this exception to the Ryan Hate Act. It says if there's an emergency, traditionally we require an in-person physical visit prior to prescribing controlled substances via telehealth. And that goes away during this public health emergency. We're going to use our enforcement discretion. So this has been, we've been living and breathing these exceptions for over 18 months now. So there's literally cottage industries of virtual SUD and OUD providers that are virtual only that have sprouted and evolved because of just those waivers. And so those are whole businesses. There's business models that are heavily reliant on those waivers. And again, these could just disappear at the end of the PHE, at least right now. So those two things, and I'll stop talking so Valerie can chime in, are not even before we get to the stuff we talked about earlier about Medicare, Medicaid, your commercial payer reimbursement. This isn't even about whether you can charge or get paid. This is just, can you do it in the first place?
Yeah. So I mean, let's talk about how that impacts the commercial payers, because I think a lot of focus is on Medicare and, how do we react from a commercial payer perspective? Of course, those state laws are going to impact that. The medical boards of the state are going to impact that. But there's certain latitudes of commercial payers. Even Medicare Advantage for non-covered services may say, well, we're going to cover telehealth because we think it's the right thing to do, and we're just going to pay for it anyway. So thoughts on that, and what kind of component of telehealth we anticipate to move forward regardless of these changes?
Yeah, so I'll talk first on commercial and I'll go back to Medicare. So commercial, we did a survey of last year and we came out in January, and we found that 43 states, so the vast majority, have some sort of commercial payer law in the books. So it'd come a long way, and that's not the COVID, just temporary. That's permanent, like commercial payer, statutory or regulatory laws. There's been a continued trend pre-COVID, during COVID, for states to pass legislation for that. And it's a little bit, though, smoke and mirrors when you really get into the weeds, which, okay, you have a commercial payer law, but I'll give you an example. Like Florida, we have in our survey, yes, it has a commercial payer law, but then you read it and it basically says, and I'm summarizing here, hey, health plan, you can cover telehealth services if you want to. It's like, well, what the heck? Like, what I would love to have seen like the debate on the legislative floor to like pass that law, right? Like, so there is some lip service to it that doesn't have, like, some of these don't have teeth. And so, commercial payer coverage is one that could mandate, and then does it have teeth? And then I think what's really going to be the next, I don't want to call it fight, but an area of debate is going to be payment parity. And so, sure, okay, we can all agree telehealth is great, but then how are you going to pay for it, and how much are you going to pay for it? There's arguments that, look, I'm a doctor, I'm a ER doc or an ED doc or a gastroenterologist, whatever I am, an ophthalmologist. Are you telling me my time's less valuable just because I'm doing it on video? So that's one argument, right? But on the other side, they say, look, the whole point of this is to drive down cost of care. And so you don't have the same brick and mortar overhead. It's less capital intensive. So this should be cheaper. We should reimburse less. And so that's the push and pull that we'll see, I think, states grapple with, and you'll see the lobbying on both sides go. And I do think it'll trend such that there will be payment. I don't know how much payment parity is going to exist exactly in-person care. We'll have to see that, how that shakes out. But for Medicare, the same thing. So Medicare, there's a lot of, and I'm very much a pro-provider advocate of telehealth expansion, obviously, so I'm biased. But the naysayers, and I'll call them naysayers, but there's probably better things we can call them, will say things like, look, the Congressional Budget Office has come out and said there's real concern about the cost and the utilization being driven up by telehealth. And we don't really know enough information. We need more studies. MedPAC has come out and said you have to be very careful with this. There was some analysis of recent bills that said it's going to add additional $4.5 billion to the cost of healthcare. So, those are the concerns of why Congress federally hasn't just opened the floodgates. And then the folks on the provider side say, well, we do have some studies, and Congress is always going to ask for more studies, and so that's part of it. But that's where I think things are from a payment perspective.
Getting back to parity, when we think about how codes come out and how the AMA pushes out codes, adds, CPT codes, and then the RUC committee actually determines what that potential value is, and CMS agrees with that value. It'll be interesting to see if there's actually surveys done on the actual cost and what that value might be, so that we can really come to a value on that, and how that will kind of conflict with these parity laws in certain states, because maybe ultimately they determine that they're not in line, and how will that conflict? Because there is an expectation for that every 5 years that these codes be reviewed. So and will telehealth actually impact the value of E&M, because telehealth is a portion of E&M visits now. So what are we really looking at from a value perspective? So we'll have to watch and see how that comes into play. So moving on, one thing in regards to the temporary telehealth codes, that there are some questions about that, and the questions provided to us, but we would expect those temporary telehealth codes to not move forward, because there is no current support for them being medically necessary or medically appropriate or effective when they're not provided in person. And that's the whole point of kind of tiering out these codes and the way that they're, have 1, 2, and 3 tiers. So we would expect that those would sunset, but watch for that and make sure that you're mindful of what will happen there. And that goes to also the types of providers that are providing service. It's been expanded to our therapists, providers of rehab and PT, OT, ST. So it's really important to watch how that's going to trend. Of course, if you think of PT, you're going to get maximum benefit if you have someone right there showing you that the types of services. But we have moved into a digital world. I mean, there's certainly types of you might even have a personal trainer online now. So, it is something that may evolve over time, which I think comes back to technology and how we apply technology in our homes, and how that will elevate our ability to provide care in the home setting. Any additional thoughts on that, TJ?
No, I don't think so. I defer to you on the coding experts.
Yeah.
The one thing I'd add is in the proposed rule, in which it's not final for the physician fee schedule, CMS did say that they're considering, so what they did was they have, the category 1, category 2, category 3 codes. Category 3, this whole concept of a category 3 code is new. They just invented it last year. And these are I believe the temporary codes that Valerie spoke about. They're proposing to do 2 things. They're proposing, 1, the codes that are category 3, they were supposed to end at the end of the PHE. What they said in the proposed rule is, let's give us to at least the end of 2023. We want to learn more about these codes. So if that passes, we have 2023 for the codes that are category 3, which are temporary. But there's also codes that were temporary codes that they did not put in the category 3 list. And those are going to end at the end of the PHE as of right now. But CMS did ask for public comment on, hey, any of these codes that are going to end, let us know, industry, if you think differently. So, the public comment period has passed, but we'll see if they lump in anything else in addition to add to the category 3 list to expand that. But I want to keep in mind that, if to the beginning of what Valerie said, the CPT code list is only one of the criteria to be met of all the other Medicare telehealth criteria if we go back. So while one of the criteria is you have to have a CPT code, and so this expansion is one prong, you still have all the other ones about originating site, qualifying rural area, and all of that. So this is one piece of the larger puzzle that would have to be solved before you really get the full benefit of telehealth in a Medicare fee-for-service context.
You mentioned the proposed rule. Evidently, the use of the word telehealth was the most used word in the comment period. There was over 16,000 times it was used. So there's definitely been a lot of dialogue around this. So, it's yet to see how CMS will react, but CMS is limited on what they can do as opposed to what Congress has to do to make real change here. So, so it will be interesting to see how that evolves. Moving into medical record documentation, there's a certain elements that are expected to be in the medical record, and then there's best practice If you look at the Medicare guidelines, if you look at CPT guidelines, if you're looking online to figure out what you should include in the medical record, you may see varied levels of expectation. We would recommend that you include that consent with the patient very clearly in the note. The technology used, because if you don't indicate the technology, it could be questioned on whether the technology you used was actually allowed during the time that you used it. So if you don't have it in the record specifically, I would recommend at least having it by policy that all of your providers are only going to use this platform, and therefore that's the platform that was used. At least you could have something to fall back on. The location of the provider and the patient, the place of service that you're using, the location that you're using is going to be based on where the provider would have normally seen the patient, but where the patient was and where the physician was is waivered right now. So, you want to make sure you're indicating where each person is so that that's clear that you're following the guidelines currently. And then there's the difference between telemedicine, virtual, and e-visits. If you're doing virtual and e-visits, indicate what type of service that you're actually doing and what technology you're using. Are you in the EHR? Are you in the portal? Are you communicating via telephone? Making sure that you're communicating what you're specifically doing and how you're really doing that. There's also already been some OIG reviews, and so you want to look and see what they're looking for. There's indication of stop and start time is one of the things that they're looking for. Now, not every code is time-based, and you do not have to use time as a basis of your code selection every time. But if you are using time, you want to make sure that you're including at least that total time. But it seems that Medicare, or at least the OIG, is really looking for that start and stop time. And so, making sure that you're including the documentation within the record, which kind of goes back to our, when you're doing compliance audits, I'm sure that many of you have been more reactive and saying, as compliance officers saying, okay, you can do this, and this is why you can do this, and this is what you have to do, but you probably haven't gotten back to saying, okay, what do we do what we said we were going to do? So it's time to start looking back and auditing and making sure those telemedicine visits are supported. So in the telemedicine visits, making sure your BAAs are in place for all of your vendors, making sure that you were actually compliant with what technology that you're using, and that it doesn't go outside of those bounds, and that you are doing security risk assessments around the technology you're using. And one caveat to that is the security insurance right now, HIPAA security insurance is going up by leaps and bounds, and it's becoming harder and harder to get insurance for your security risk. And so it's going to be interesting to see how that impacts telehealth, because if you have a lot of different vendors or devices and tools and things like that, that increases your risk, and you may become less insured, or you may adopt a device that is not insured. So making sure you're monitoring that as you go will be important. So clinical practice, one of the things to think through is what providers are really comfortable doing in a telehealth space. One AMA survey that was done said that more than 75% of clinicians indicated that telehealth enabled them to provide quality care in the areas of COVID-related care, and acute care, chronic disease management, hospital ED follow-up, care coordination, preventive care, and mental health and behavioral health. So there are certain areas and specialties that are going to be in line and more easily adopted for telehealth. So we want to make sure that we're in line with the providers and their comfort level with actually utilizing this. But one of the AMA like on their telehealth website, they've shown how Henry Ford has adopted some devices that allow you to send that device to the patient's home, and they're able to see in the patient's ear, they're able to see the eye, their nose, throat, looking at your heart, your lungs, pulse ox, weight. So there's a lot of data that can be gathered, and the providers were very accepting of this because they could actually see better than the naked eye sometimes on some of this equipment. So there may be adoption as we get more technology and are able to do more, but there is nothing to be said for, I mean, if you cannot touch the neck and confirm that thyroid is not swollen and lymph nodes are not swollen, and the abdomen is not tender and distended, and splenomegaly and all these things that we're looking for. I mean, there's malpractice risk. There are all kinds of things that are going to come into play as we continue to push this forward. So be mindful of all of those things. So as we look forward, as we really kind of get prepared for our next steps, a lot of us, I think, will be taking a wait and see approach. As TJ mentioned, it's very difficult to make decisions when we don't know what's about to happen. When we have 8 days before something might happen, we don't know if we're going to have that cliff or not. So I think we'll be planning for a blend of services, planning for a certain percentage of telehealth services, planning for the ability to our disaster planning. For the blizzard in Texas, they were able to respond to more patients because of telehealth. There's all different kinds of reasons why we want to be prepared, even if that's an outsourced option, that you say, okay, well, if something happens, we're going to outsource to this vendor, and this vendor's been vetted and we have a contract in place and that kind of thing. Or you have the equipment and tools in your EHR that allow you to utilize technology that will be permitted going forward. So let's watch for those tracks and trends. But TJ, any additional thoughts on making sure that we move forward wisely?
Yeah, so there's like a wish list, right? And I think there's a good chance that we get some of the things on our wish list, and I'll mention in a little bit some of the pending legislation that could fix some of the issues. But there are some that are definitely going to end. We don't know maybe exactly when, because we don't know exactly when the public health emergency will end. But the ones that I had mentioned earlier from the federal agency side, those are going to end. So, for example, the copayment obligation is going to come back into play, right? So the OIG saying they're going to use enforcement discretion and not come after folks who are not charging the copayment, especially under like Part B for a telehealth visit or RPM. That's going to end. And so if you're an organization that maybe just started your RPM program or a telehealth program during COVID and have never really built in the process to collect a copay, that's something you should start right now to be able to do, because it's not a matter of if, it's when. So start that process, start the training. Similarly, for the OCRs waivers, you may want to do an assessment of what tech vendors do we have that we don't have a BAA with or not HIPAA compliant. We got to put that back on our radar, because once the enforcement discretion ends, those requirements are going to be part of your compliance obligations. And another big one is the DEA, Ryan-Haight Act. Like I had mentioned, there's a lot of these virtual only, companies that rely heavily on controlled substance prescribing. And so you'll have to really reassess your business plan and maybe pivot so that there is a telepresenter, or there is a way you can satisfy a component of the Ryan-Haight Act exception, or at least at a minimum understand that you're taking on a significant or some risk when you have a component that doesn't satisfy the Ryan-Haight Act. And so those things you need to start putting on your to-do list, because they will happen. Then on the wish list items, there's some of the bills that have, I think, the most legs on them are like the Connect for Health Act. That has a really good spread of items that we would want to have passed. It eliminates the geographic restriction requirements we mentioned. It actually helps a lot with giving HHS authority to have more flexibilities, especially if there's future public health emergencies. It calls for a study to study telehealth. It allows rural health clinics and community health centers for permanent telehealth. So that's kind of like a really good wish list there. Has great bipartisan support, but it's a big bill. The public affairs folks I've talked with say, while it has a chance, the best way, or the way we think it might happen, is certain provisions are going to get pulled from it and be dumped into like the budget bill or the appropriations bill, like everything else, right? So that's what we're hoping to happen. The other bill that I think has a good chance, although it's new, is the Telemental Health Awareness Act. And that one is very focused on just eliminating what was passed effective January 1 of this year, which was basically the legislation that says for mental health services, you can provide those via telehealth and get paid for it by Medicare. But they snuck in this clause that says you have to have had a physical in-person visit within the previous 6 months and every subsequent 6 months. And so that's, basically a burden. It doesn't exist for any other Medicare telehealth type of service. And so that legislation that's pending is to fix that particular piece. And so, from a payment perspective, what you want to think about is, yes, we're hoping that payment is going to be expanded, but if it's not, then what does that mean for our business model? So I'm going to give an example. If you have a patient that you now have a relationship with during COVID, you're treating them at home. If the public health emergency ends, you still have that patient relationship. You have continuity of care obligations. You have patient abandonment issues. What you're faced with now, though, is you may not be getting paid for a service. So telehealth may not pay for that visit. But here's the kicker. You can't just provide it for free either, because that could be an inducement for other reimbursable for services. So as a provider, you're now wrestling with a panoply of patient abandonment, continuity of care issues. You need to make money to stay in business, and you also can't offer it for free because of other healthcare regulatory. So you need to address that by looking at your options of, okay, maybe we just have to charge this cash. Our patients, maybe we start notifying them if we do get a 60-day notice about the PHE expiring. Hopefully we do. You start notifying patients that this charge is no longer going to be free, or the service free. We'll have to charge for it, or at least a copay, or transition that patient's care. Those are the kind of things to be wrestled with if the payment process ends. It implicates other fraud and abuse laws or compliance laws. So those healthcare clients that we have there have gotten heavily reliant on these waivers need to start weeding themselves off and plan that if these things go away, how am I going to make sure that we're still in compliance with the least amount of disruption?
And certainly we would expect, on any given day when a patient is being seen, you're determining the best course of that patient's care based on what will be covered. And so that you would do your normal eligibility checks. And if they're technically not covered, then you would convert them into patient pay or, patient responsibility. If it's not clear, you probably want to provide them an ABN, an advanced beneficiary notice, so that you can say, okay, this might not be covered, so it may be under your responsibility. And then making sure your consents are in line with whatever's currently going on, and making sure that those are appropriate. Another aspect is that RHCs and FQHCs have had a significant coding change related to these services, and they're very specific to COVID. So you'll want to watch for the changes to occur as the PHE ends, determine if you should continue to use the current codes that are out there, or if you should revert back to the original codes. My guess is that we're going to have some kind of blend of that going forward. And certainly, as TJ mentioned, there's a lot of thoughts around, continuing this within the rural health area anyway. So, what do we need to do going forward? So monitor that probably every 15 days, because as we saw during COVID, everything changed, basically almost daily as it started. So we should not expect anything different as we end the PHE. So be really mindful of what is CMS saying? What are the FAQs that are out there? Are there any interim final rules that are out there? That kind of thing. Watching for those. Are there any specifics that are coming out of your Medicare administrative contractor? All of those things will be important to monitor, but don't forget that every single state, every single payer has their own bent and turn on this. So it is very difficult right now for national companies to follow the rules. And so eventually we've got to get to some place where national companies can function and compliantly, because it's becoming very difficult and kind of counterintuitive from a cost perspective to actually follow the rules. So there'll be high enforcement and high difficulty to actually merge and become a national presence. Any closing thoughts, TJ?
Yeah, the last thing I'll say is, because we've made a couple references throughout the presentation about like the crystal ball, which I'll probably never want to hear again after COVID. But the we don't know, or we don't have one, right? But maybe we can make one. In the way I really encourage on all these conferences and presentations is, especially because a lot of this needs to be driven by congressional action. Your organization, you as a stakeholder, really should make your voice heard and call your congressman, join the various trade associations and push it, because that is working. It will get us momentum to get those changes. Submit comments to public comment sessions for like CMS. They read those, they look at them and take it under consideration. So, let's just not sit on our hands, but the more action we can take, as stakeholders in the industry, that's really how it's going to move forward. And I've seen it. It's how the telehealth industry has moved forward to date. And now it's a little bit more, I think, time sensitive, given that the situation we're in, since we've had a taste of this model. And so I would encourage everyone on this presentation or conference to join in and again, make your voice heard.
Great, thank you, TJ. Well, we will be submitting a blog in the next few days, kind of wrapping this information. Any questions that you had that you posted, we'll try to wrap those in as well. But if you have any specific questions that have not been answered, feel free to reach out to me or TJ, and we'll be happy to help you. So thank you all for your attention today. Jana and Angie, any closing comments?
Thank you, Valerie. Thank you, TJ. Thank you, Foley and Lardner, for another great Let's Talk Compliance. Please answer your surveys, attendees, as they will come out via email. We want to hear from you. We want to hear feedback on future topics. So please respond to that. It will help us plan future events. Jana, any thoughts?
No, again, just thankful for everybody's attendance, and give us those thoughts on next presentations. And thanks very much to TJ and Valerie. Really great presentation.
Yes. Have a great day.
Thank you.
Bye-bye.